see in terms of flights or delays, who was impacted on the way here? Okay, and I know we have a couple of folks who haven't been able to join us today. But that makes me even more grateful. I think that we could all be here, and thank you so much for prioritizing getting here and still being part of this meeting. We're really, really grateful. So my name is Jennifer Deal. I'm one of the co-PIs of the Sense Network. And this is our conference on thinking about sensory health and well-being and
if you want to, thank you.
So we wanted to start with just our own visual descriptions. So I am a middle-aged white woman. I have shoulder-length gray hair, and I'm wearing glasses and a black jacket.
And I'm a youthful, mostly brown-haired, little bit of gray male, and I'm wearing a blue shirt. And
we also really want to prioritize accessibility as part of this conference. So we do have CART and ASL available. Those are both available through the Zoom link. You can access the transcript here using the QR code. And just a note for all of our participants in the room to help with accessibility, and particularly with that CART and ASL, when you have comments in the room, if you would please use the microphone, that would help everyone online as well too. Another note is that we would love to see your pictures. If you take any, we have some disposable cameras for some of our work group leads, and I've asked them to take some pictures for us. But if you have any that come up in the next couple of days, then we would love to have them. So we wanted to start a little bit and just introduce the Sense Network to you. So the whole goal of this network, which includes everyone else and that is here in this room, as well as others at home, our goal is really to think about building the infrastructure to address critical barriers that are hindering progress in the field of sensory aging research. We have a really outstanding team. We have a Sense Network steering committee that's headed by myself and Josh Ehrlich, and we're the co-PIs. Also Lindsay Delott, Alden Gross, Ken Lenga, Frank Lynn, Jay Pinto, Nick Reed, and Varshney Verdaraj. We are advised by an advisory board that includes Vicki Friedman, Hank Paulson, thank you, Kathy Pickera-Fuller, Bonnie Sweenor, and Heather Whitson. And then we're organized into 3 cores, and each core has their own kind of focus. So we have the data collection, harmonization, and integration core that is led by Alden Gross and Nick Reed. We have the research development and mentorship core that is led by Jay Pinto and Varshney Verdaraj. And we have the dissemination and translation core that's led by currently Lindsay Delott, and I'm helping her since Frank has made a move to Apple. But we really owe this conference to our research and development core. And I just want to take a moment and thank so much to Varshney, and thank you to Jay for putting this all together. We really appreciate it. And I also need to acknowledge the people who made this happen. We had a vision and they actually made it happen, and they are in the room right now, mostly in the room. So Sue's is really been instrumental to having this conference come off. Mindy DiMuchowski, who's here. And then we're very happy to be joined by Katie, as well as Justice, who are here today to help us as well. So thank you guys to everything that you've done. And I know that you've had so much communication with them today. And then also just to give you a sense of where our funding comes from. So we are supported by the National Institute on Aging. It is through an infrastructure building grant mechanism, which is the R61, R33. And so the R61 is a 2-year grant where we have certain milestones, including this conference. After we've shown that we've successfully met those milestones, we will be able to move into the last 3 years of the grant, which is the R33 mechanism.
And so when we put the grant together, we had to articulate to NIA, to the grant reviewers, what our aims were for both the R61 phase and for the R33 phase. And so those are shown up here. And really, yeah, as Jennifer just mentioned, a big piece of what we're doing is the successful consensus conference. You see there, second row, second column. And the product that's meant to come out of this meeting here, as we meet in our work groups, as we talk through priorities, where we've gotten in recent years, where we want to get in future years, is a white paper detailing this for the community, for other researchers, and really trying to set kind of the foundation for research and research priorities going forward. And so that's one of the major outputs that we anticipate, the major output we anticipate from these couple of days here together. But other things that we're doing besides this key output in the research and mentorship core include creating a data bank to help make sensory aging data more discoverable. And that actually, I hope I don't misspeak, Nini, you can help me. It's supposed to go online this weekend. And there'll be a QR code on one of the posters showing you guys how you can access that. It'll be on the Sense Network webpage as well, which is sensenetwork.org for anybody who doesn't know. That hopefully will be a widely accessed resource for people to make use of sensory aging data that's out there, but sometimes difficult to find or to know kind of what measures are included. We're also developing a curriculum for practitioners and researchers who are new to or hoping to make progress in this field to be able to gain some basic education through online modules and online learning around sensory aging research. And then we have other aims that will be pursued in the next phase of the grant in the R33, and one that maybe that I'll just highlight instead of reading through all of them. One that I'll just highlight is that starting in the first year of the R33 phase, about a year from now, we'll be making pilot grants ideally for mostly junior investigators who are seeking to launch careers and to make use of some of the data resources that the Sense Network is creating and providing, and to drive the field forward as the next generation of researchers. So keep an eye out for that as we transition to the R33 phase for those pilot grants. But right now we're in the R61 phase. And as I mentioned, of course, the consensus conference is a big piece of the R61 phase. And so we're happy that you're all a big part of it. And so here we've sort of highlighted what the components of that, the consensus conference are. Some of you participated in the Delphi exercise, where we sought to compile a list of priorities in various domains like measurement and intervention, these work groups that we'll be participating in this afternoon and tomorrow. And that feeds directly into today and tomorrow's meeting, that consensus exercise. And then the publication of our findings, of course, is the next phase. And so we're delighted to include all of you and have all of you as important contributors throughout that process. And so the consensus conference, as we've conceived of it, its purpose really is to build consensus of research priorities, address knowledge gaps, and identify actionable next steps in this field of sensory aging, well-being, and with an eye towards cognition. That's an important piece here, although not to the exclusion of other areas of interest. And so we want to start today with actually a reflection on the progress that our field has made in recent years. Some of you may be familiar with the 2017 white paper that came out that kind of set the stage for research on sensory health and cognitive health. And we'll be reviewing a bit in the subsequent session, that white paper, and also where we've gotten in the past 8 years since that was published. We'll talk about the Delphi exercise and what came out of that. And very exciting, we'll have some patient perspectives that we'll hear from this afternoon about prioritization and what we should be thinking about from the patient perspective, which is very exciting and obviously quite important. And then ultimately, we hope by the end of the day tomorrow, we can say that we have some consensus-driven recommendations on where to go from here. And so just an overview of today. I know all of you have a copy of this in your folder. I've alluded to some of what we'll be doing. We'll be talking about what we've accomplished since 2017. The Delphi exercise will come after that. And then we have some patient perspectives. And we'll get started on the work groups, which will form the crux of tomorrow's activities. Should anybody have any logistics questions or concerns throughout the day, Suze and Mindy are available to help us all out, as they've been such an amazing help so far, and we're very pleased to have your help in over the next couple of days. Any questions or concerns, or anybody want to add anything? Now we'll jump into what we're all here for. What if we have everything teed up for the next one, or if it's this is not what we can do.
At this point, Nick, if you'd like to invite you to come up too. Thank you so much. And then Um, thank you. So I have just a couple of notes of introduction for this panel. And then I'm very delighted to turn it over to our speakers. So we have Dr. Josh Ehrlich. Dr. Alden Gross, unfortunately, is delayed. He is on his way. He will be here this afternoon. So taking his place on the panel for us, thank you. Excuse me, Dr. Nick Reed. And then Kathy Picker-Fuller is online as well. So thank you, Kathy, as well for joining us. So as Josh mentioned earlier, there was a conference that happened back in 2017, and this was a conference that was organized by Heather Whitson, who's a geriatrician at Duke, and Frank Lynn, who at the time was at the Johns Hopkins. And the goal really was, it was through an American Geriatric Society and National Institute on Aging Bench to Bedside grant that really funded this work. And it was looking at sensory impairment and cognitive decline in older adults. So this was a paper, some of us participated, but I know not everyone got a chance to participate when this came out. I do note here, I've got the picture of the ear and the eye, just to remind me to tell you that they intentionally limited their discussion during that conference to hearing and vision because they were trying to narrow the scope. That is not our charge today. We want to think more broadly about all of the senses. I see some thumbs up in the audience, which is great. I will say what they identified was 3 priority areas. And so it was a 2-day conference similar to what this was. And their priority areas that they identified were mechanisms, measurement, and intervention. In terms of the mechanisms, there were a couple of key points that they raised that they thought should be addressed. And that was understanding causality of the relationship between sensory and cognitive function. Is it causal? Is it not? Right? Big picture questions. Also, they wanted to understand more about the identification of neural and biological mechanisms with an emphasis on targets to improve care that affects sensory and cognitive health. In terms of measurement, there were 3 priority research gaps that were identified. One was the normative data. So what are the norms of existing tools across different populations, including those that are underserved? The development and validation of new tools and protocols to manage cognition in the setting of hearing impairment, visual impairment, and dual sensory impairment, and new approaches to measure sensory deficits in older adults with cognitive impairment. They also wanted to focus on the inclusion of broad measurements of cognition, hearing, and vision impairment in existing studies. So expanding the current data collection in studies that were already ongoing. In terms of interventions, so they were interested in the effect, feasibility, and accessibility of existing interventions in people with cognitive hearing and vision impairment, as well as innovative interventions and protocols designed to improve sensory and cognitive outcomes or to accommodate sensory and cognitive impairment. So you can see, I think, some of the things that were outlined, there has been some progress in. Some of them, I think there's not been as much as we would have liked to have seen. And so for this panel discussion, when we open it up, and we'll start with our panelists, but we welcome thoughts from others in the room and online as well. what progress really do we think has been made since that time? It's not been that long, but yet it seems like forever ago. And there are a lot more of us, I think, now, thankfully, in this field. And I do think there's a lot more crosstalk across disciplines. But what is progress has been made? And then, of course, what gaps still exist? So what do we also see as priority areas for future research? So with that, I'm going to stop sharing just so that we can put all of our panelists on up. And I also want to be able to see Kathy as well. Oh, I stopped sharing, but it's not, it's still showing up on the screen. Let's see. Yes. Yeah. I just had to stop sharing. And then is there a way to spotlight our panelists? Do you know? Is that through Zoom too? While we're working on the tech to get set up, I wonder if we can go ahead and get started. And Kathy, I might ask you to go ahead and start by just introducing yourself.
Okay, can you hear me?
Yep, you sound great.
All right. Well, thank you so much for inviting me. And I'll just say off the top, also thank you for creating SenseNet, because I think much of the progress we've made has been accelerated because of SenseNet. I'm clinically an audiologist. My research is in cognitive psychology. And hey, now I'm an old lady. And so I have a bit of the lived experience perspective. I'm coming to you from the traditional lands of the Squamish and Musqueam and Tsleil-Waututh First Nations from Bowen Island, which is a short ferry ride from West Vancouver in Canada. So I will try to bring a little bit of a global perspective. I've done a lot of work with the WHO in the time since the 2017 paper.
Thank you so much. Josh, can I go ahead and ask you? You've done a little introduction, but just we haven't done titles.
I think so. So yeah, in terms of titles and what we do, my name is Josh Ehrlich. I'm faculty at the University of Michigan in ophthalmology and also in the Institute for Social Research, and also do a lot of global health work like Kathy, and I'm an associate director of the Center for Global Health at University of Michigan. Primarily a lot of my work focuses on vision and cognition, but also increasingly collaborations with people across the senses, and because none of what we observe really happens in isolation. So broadening that perspective is we all, I think, agree, is very important.
You're a terrible person to work with.
Thanks, Nick.
I'm Nick Reed. I'm an associate professor at New York University in the Optimal Aging Institute, otolaryngology and population health. Broadly, my work focuses on hearing loss and aging outcomes, more narrowly, hearing loss and delirium and hearing loss and healthcare utilization. I also lead uniquely the only hearing reading core sort of in the world for epidemiologic studies, where I think at this point we've added hearing measures to something like 14 epidemiologic studies around the world, with something like 120,000 measures in the past 5 years contributed to the literature. Yeah.
Thank you. So you are filling one of the gaps that was identified as that priority area. So thank you so much. At this point, and I can have some more specific questions later, but I'd like to just open it up broadly to the panel to see if there are any initial reflections.
Well, I think I would like to just start by saying, when I look back at that 2017 paper, which I have cited many, many times, I thought, wow, has the world ever changed since then? So I think there is, progress that's been made in our research, but I really think that the world is a different world now, and the population continues to age. So I think this is a great time for a new consensus to look at the context that we're working in, as well as looking, inside our own more encapsulated view. How do we connect to this bigger world that we're living in?
Yeah, I think undoubtedly agree with with everything that Kathy just said. I think when we think also in the research realm, a lot has changed too in the way that we do research. I'm particularly thinking about the integration of artificial intelligence into a lot of what we're doing in research, or many people are doing in research, including in the vision and cognition space in particular, where we're very, very interested in the eye as a biomarker. And so there's been a tremendous amount of change, both in populations, in demographics, but also even in the way that some research anyway is conducted. In terms of the gaps that were cited in the 2017 report and kind of where we are now with respect to some of those gaps, I think we're like 50-50, right? We've made some real progress in certain places, and in other places, I think there's really been relatively little progress in the past 8 years. And in a large number of cases, I think that those areas, and I'm thinking particularly about mechanisms underlying the sensory cognitive relationship, one of the really challenging pieces there is needing appropriate longitudinal data, which is hard to come by, to really be able to suss out those mechanisms. And so I think that remains a really critical gap. And, I also, like Kathy and like many in this room, I'm sure, have cited that paper innumerable times, because one of the great things in that paper is that it lays out in a really, really articulate way a series of underlying hypotheses that may account for this relationship between, in that case, it was vision and hearing only, but I'll say sensory health and cognitive health. And I would say 8 years later, we don't know too much more about those pathways and which ones are most relevant for whom, because clearly I think it's clear anyway that there's probably not a singular pathway that applies to all people. And so to me, that stands really front and center as an area where somehow we have to produce in diverse populations, because it's not necessarily the same everywhere. We have to produce the data that's needed to figure out these mechanisms.
I was only asked this 5 minutes ago. So I'll channel Alden somewhat. I think when we're thinking about mechanisms, I would build on that and say, we still are at the infancy of what the potential causal mechanistic links are. I think we're also still at the infancy of, potential confounders in this that we haven't thought about before, and things that could cause hearing loss that also could contribute to pathways causing sensory or cognitive decline, like noise, right? We know a lot about noise damage, and noise exposure, but we still haven't included it in many of the epidemiologic models because it's usually poorly understood. And perhaps what's happened is, I know from the measurement side, we are now in demand, right? It used to be that I would reach out to a study and say, please, I'm begging you to let me add hearing measures to your study. And now we're getting a call every month with somebody saying, I want to add hearing measures to the study. And I think as we keep integrating into these new studies that have better genomics, better environmental exposome, we're starting to say, oh, maybe there are other things and other pathways that we haven't truly thought about fully here. And so I think that original DAG has probably exponentially expanded to actually make it that the gap gets further and further away. But that's good, because that's what science is supposed to do.
And just for, if you don't know what a DAG is, it's a directed acyclic graph. It's an epidemiologic tool. It's like a causal diagram.
Jargon.
Yeah.
I think we'll move on to measurement in a minute. Is that right? Or...
To give Kathy a chance to comment.
Can I just expand a little bit? So when I started thinking what has happened, in the world of audiology, and I know less about vision, but I think there are parallels. So I'm thinking, in 2019, we had the WHO World Report on Vision. In 2021, we had the WHO World Report on Hearing, and we had subsequent accompanying documents about screening across the lifespan, including in older ages. I think really there was a fabulous breakthrough in 2017, the same year as the original consensus report, but a second edition in 2024 of the WHO Integrated Care for Older People, where they identified 6 key capacities, hearing, vision, and cognition being half of the 6. The other 3 were mobility, mental health, and something they call vitality, which includes things like nutrition and cardiovascular and metabolic factors. So I think they have, with that concept of integrated primary care, given us a bit of a light in the forest for how to take what we have learned to mobilize knowledge about sensory aging and how it plugs in, not just to cognition. If I had a magic wand, I would not put cognition and dementia as the end point of our endeavors. I would put healthy aging. And I think cognition is special because it's sort of, the brain that coordinates all of the inputs and actually also coordinates with motor outputs. So I know we're interested in the central nervous system and the power of it as an integrator, but how do people function in everyday life because they can capitalize on that or not? And how can we get them functioning through rehabilitation? I recently saw a NASM online webinar also about the autonomic nervous system and the emergence of interest in the brain and the gut and the brain and the heart and the brain and the lungs. And so I think, it's good, it's practical to kind of restrain the problem space, but maybe we have to think about how we actually enlarge it, because otherwise we may be, if we ever find the needle in the haystack, what good is it going to do us? What is our actual objective? Is it to get people to live so that they can do and be what they value as healthy aging people?
Ready to move on to measurement then?
I don't know. You tell me. You're in charge.
Yeah, I'd say go for it.
I think measurement for me stands out. I just spent the past year and a half on a NASM committee producing sort of a standardized core outcome set for hearing research and hearing clinics. And when we think about the measures and the norms, I think we take for granted this idea of normed data, and I think we take for granted when we say the term valid in general, right? We've been using a lot of measures and tools that someone says are valid, and then we run into the same problem all researchers have, where we're just citing what another paper cited, and then when you actually look it up, the majority of the tools we have in audiology, for example, are not validated. They're not reliable. They haven't been repeated, and I think we learned the hard way in creating that core set that we are way further behind than we thought we were. I think we came up with 4 measures total, that 2 of them were also just sort of recommended out on a limb because they met construct areas. But we had almost no speech and speech understanding or speech and noise measures that were truly valid or truly reliable. We had very few questionnaires that met that, including questionnaires that we see being used in the epidemiologic data. And when we looked at the populations that created them, a lot of them were small N of maybe 200, assisted living facilities. And during the process, we got a lot of sort of in progress data. And I'll use the example of the HHIE, the hearing handicap for the inventory for the elderly, which is poorly named, but it was created with 240 adults in a nursing facility. It's been used in clinics throughout the world, but when we implemented it in the ERIC study, atherosclerosis risk in communities, with 4,000 older adults, and we looked at some of the data interim during this NASM committee, we actually found that if you run sort of lasso models, one question drives the entire outcome of the study or outcome of the questionnaire, except it differs by whether you're in the southern United States or northern United States, which question that is, which says a lot about how reliable and valid our tools are. And I think, I actually think that when it comes to norms, we're still living in sort of this nebulous area. Another great example in auditory might be that, I don't know if everyone knows, but in 2023, when the World Health Organization released their World Hearing Report, they also changed the cut point for hearing loss on a 4-frequency pure tone average. Overnight, we went from 40 million to 83 million Americans having hearing loss. I don't know what that says about norms, but it says something about what we're doing as a field. So I don't know if vision has the same problems, but I think auditory, the attention we got from population level actually threw out of whack a lot of our sort of accepted norms, and that we're now sort of more in a volatile moment.
Yeah, I think the situation is not too terribly different when it comes to vision. Many of the norms, the sort of cut points and definitions, like you were just referring to, are in many ways not necessarily tied to any construct that's appropriately meaningful. And I'm thinking mostly of visual acuity, because in many cases, when it comes to vision, which is such a multi-component construct, visual acuity is so often the only component that's tested, even in a clinic setting, let alone in a research setting. Even when we have evidence that there's maybe other visual functions like contrast sensitivity that may be more predictive or more important for outcomes like well-being, perhaps even cognition. These tend to be overlooked. And when we do look at them, we don't have established cut points that are tied to anything meaningful. So it becomes very difficult to understand if somebody's fallen into an area of contrast sensitivity function that's of concern without having those sorts of established norms. Of course, dichotomizing things comes with its own drawbacks also. But we do need sort of a set of norms to be able to talk about things like prevalence and incidence, which we don't always have. I would say when it comes to measurement tools as well, I think in the vision space, we're reasonably good when it comes to the clinical setting. But as soon as you get outside of the clinical setting, we have a hodgepodge of measurement tools. Many of them are, for convenience sake, tablet-based. They can easily go in, or cell phone-based. They can easily go into the home. They can go into the most austere settings, anywhere in the world. And we can get a measure that in many cases is fairly reproducible. But there's not a singular established, this is the measure that actually is the most reproducible and is actually measuring what we want to measure. So we struggle with that for sure. The survey-based measures are also somewhat problematic, and a big piece of that in the global context is that they don't translate well from one place to another. And I don't necessarily mean linguistic translation, that's the easy part, but the cultural translation can be quite difficult, as can the keeping measures up to date. A lot of the most commonly used measure, survey measure in vision, is the National Eye Institute Visual Functioning Questionnaire 25, which says nothing about screens because it was developed before screens were so commonplace. But you ask somebody about reading a newspaper or doing a needlepoint, and these were things that seemed more relevant at the time when the measure was developed. And so these things need to be adapted both to the current time, but also to the place where one is using them. And it's not necessarily clear that we need to be sticking with what has always been done. And I think that's probably true in science in general, but certainly something that comes up when we think about norms in the vision space. And I do think that that's a place where we could really, it sounds like a cross vision and hearing, if not other senses as well, a place where we as a network could really make a difference in terms of establishing norms and doing so with good evidence. And that could even be a place where people looking for a pilot project, when that money is available, to look at reproducibility of different measures and that sort of thing. It could be a good use of that sort of resource.
Fantastic, thank you. I want to give Dr. Pickler-Fuller a chance to comment.
Yeah. So I think the 2017 paper had quite an emphasis on biological and in the World Health Organization International Classification of Functioning space, I would have said mostly it was a concern about the impairment side of the landscape. And I think, as kind of taking the lived experience perspective and work I'm doing now with seniors in my community who look at our graphs and say, hey, they stop at 80. So what about half of us in the room who are over 80 a long time ago? So what is their life like? And I have worked in the clinic, I've worked in the lab, but I have amazing new insights by seeing how these 80-plus-year-olds live. I have seen people with hearing loss who are competent hearing aid wearers who are in touch with their audiologist cry because they say it's the first time they could participate in a meeting because we added captioning. So I understand, cut points and things that are useful. So I'm not saying they're not useful, but I think we really have to be more imaginative about how we look at the participation end of the ICF and what can people do well or not, and how do the combination of hearing and vision and mobility and other health factors kind of combine, and when things are not meeting the person's desires to be and do what they value, how do we start to work on this as a package? And the person who can't see the captions, they're still stuck. So how do we get them to see the captions if they have a hearing loss? So I think in the end, we should not throw out the self-report measures, and we, if anything, should think about contextualizing them. In some of the work we've done in long-term care, should we get nurses to screen hearing and vision? And can they do it? Well, yes, they can do it on some people, but they can't do it on other people. But those other people still have important functional needs. So we kind of revert to observation. So I think the measurement story will never be simple, but we have to confront the complexities.
So much.
Let's just add one thing.
Yeah, of course.
I think that's, Kathy, I think you bring up a really great point about the self-report piece, and it's so critical that we don't throw that out. And I think it's really critical that I think there's probably a much better understanding in this room than maybe there is broadly in the scientific community that they're both important, but they're important for different reasons. And I think it's incumbent on us to describe why they're both important and the way that they both tap into different important constructs that are correlated but distinct. And I think that we sort of risk throwing out the less objective, putting that in quotes, self-report if we don't do a good job describing the importance of it and trying to get at what it's measuring, which is not always easy. It's it's a latent construct. It's not always easy to get at that. But I think we need to do a good job, whether that requires some qualitative work or what have you, to really get at that.
I think it's also, I know technology is a topic of deliberation here, but, the fact that we measure vision aided and hearing unaided is kind of a like, yeah, maybe we just actually need to understand if somebody is using technology, what do we measure with the technology that they're using? Because that has more to do with their everyday life.
Thank you so much. Looking at time, I wish we had scheduled longer for this panel. I think it's such a great discussion, and we haven't even got to intervention yet. But so I would say maybe just want to give the opportunity for all of our speakers for just maybe a 30 to 45-second wrap up. If there's any ideas that you have that haven't been discussed yet, or if you'd like to talk about intervention, or, I think one of the points of this conference is, do we even still think these are the 3 priority areas, or are there more priority areas we should be targeting? So welcome broader comments there as well.
Let me just kind of put on the flag out that I think we need to talk about knowledge mobilization. So how do we get what we have learned into use and implementation? And I think there's been atrocities committed in social media. And so we really need to have, the real evidence, as it were, in the hands of other scientists and clinicians and the public and policymakers. And I think I look to, I know my colleagues who've worked on the Canadian Longitudinal Study on Aging and our CCNA are there in the room. But I really like the interventions where hearing and vision are integrated along with other domains, which will contribute to brain health. So I think integrated rather than separated intervention is where we have to go.
Thank you.
I couldn't agree more. I was going to say, I think in a weird way, the intervention part might be somewhat also go back to basics with the difference between population and individual effects, and understanding heterogeneity and treatment effects may be a priority. I mean, given we had this large trial in the Achieve trial, and we see a subgroup that benefits, and we've been able to recreate it in different ways in secondary analysis, but it tells me that there's more about who benefits that's important to start to understand. And we are unfortunately oftentimes taking a population level average effect and trying to apply it to individuals that is sort of nonsensical, and it creates sort of a poor message that, you know, hey, this is going to change your individual trajectory by 40% or 50%, and that's not the appropriate interpretation. And so knowledge translation, in Kathy's words, is where we have to be focusing, I think.
Yeah, I don't have too much to add there. I would agree, and I referenced that earlier when we were talking about the mechanistic part, that I don't think there's any one mechanism, for example, that applies to all people. But so too, this concept of effect modification, to put it in epidemiologic terms, is rampant, and all too often I think ignored, and average effects are what's articulated. And so we do have to be creative. We have to think. We have to provide evidence as to kind of what those groups are that are more or less likely to benefit from interventions, to see certain effects in the data. And I also think, because we're here talking not about just vision and hearing, but all the senses, including balance, in addition to the traditional 5 senses, that this idea of multisensory integration, which I know there are some people here who work specifically on that, is hugely important, and something that wasn't really a major focus in the prior report. So maybe something we can be thinking about also.
Fantastic. Thank you so very much.
I would also just add, we have technology, but why don't we have environment? Because, making the world more age friendly and more accessible, that goes beyond the individual. That is at the community level. So technology, maybe we think of more at the personal level, but it could also be thought of in an institutional level. So we aren't really mobilizing. We need to mobilize at many levels, individual to community.
Thank you so much. I will say we have one quick question in the chat, and that is: smell and taste are behind the other sensory areas for being able to test people and measure smell and taste objectively. And the question is about advice from other sensory areas like vision or hearing on how we get to universal annual screening for smell and taste. And so I don't know if we necessarily have time to respond to this now, but I will, of course, let our panelists, if they have a comment on that. But otherwise, I think that's a great question to think about as we move into our working groups.
I think the logic of that could fit into the integrated primary care approach.
Thank you, Kathy. Okay. Well, thank you again so much, Kathy, Nick, and Josh. Really appreciate your perspectives.
Thank you.
And at this point, we'd like to talk about what we have learned from the Delphi exercise. And so I'm happy to welcome, it's Lori and Heather. Thank you so much, Lori and Heather, to the stage for that. I will switch the view. I think probably that would be best. Sorry, Mindy, I'm not sure which one to do. Oh, stage cam, lectern cam. It's messing. Okay. Get it set up so they can see you too.
Thank you so much. I'm Dr. Heather Kane from RTI International. So I'm coming to you from North Carolina, as is my colleague Lori Hinnett. I'm going to get started today. In this session, we're going to be pulling the thread from the other panels. So what you heard earlier that, hey, we've made about 50-50 progress since 2017. You're going to see some of those very same themes surface from this Delphi panel today. So if you feel like you're having some deja vu from earlier, there's a reason for that. So I'll tell you a little bit about the project at a high level, and then I'll hand off to Lori, who has been the chief facilitator for the Delphi process. Okay. All right. So we know that there are many questions that the field wants to be able to answer. They want to know about the pathways and associations, what interventions work, what policy interventions might need to be put into place. And we have a few examples of those big questions up on the slide. But the goal of this particular project, the Delphi process, was not to answer those big questions. It would be great if we could, but we wanted to get to a set of consensus statements to guide researchers and clinicians on how the field might advance. So through this Delphi process that Lori will talk about in a few moments, we're hoping to develop a set of consensus statements about sensory aging and Alzheimer's disease and related dementias to guide and inform researchers and clinicians working in the field. And so we're going to look at those gaps. We're going to look at investments and priority outcomes to move the field forward. And so hopefully we'll get to that manuscript phase of those consensus statements. I hope that wasn't too humorous, but I hope we'll get there. So to start the project, we started with a literature scan, and it was not meant to be a systematic review. Instead, it was a curated set of 100 articles in the field that represented individual senses as well as multisensory studies with a focus on epidemiological studies. And then members of our panel could add in some articles and additional recommendations. What we did as a team, we abstracted findings, some key outcomes, research questions, and recommendations from those articles. And we used those and shared those with the panelists. So we had a common terminology, a kind of a starting point and foundation for our discussions. The central approach that Lori will talk about in a moment is this Delphi process. And so the short version, the teaser version of the Delphi panel is that it is a group discussion and consensus building process with the goal of getting to those statements. And then here are the list of our esteemed panelists. The SENSE network was very intentional in curating a panel of individuals who are experts in sensory aging, as well as represent a broad range of sensory areas. So we're very fortunate to have this esteemed group of 12 experts volunteering their time and expertise. And some of y'all are here today, so we welcome your sharing during the discussion time. So with that, I'm going to hand off to Lori, since she has been integral to the Delphi process.
Thanks, Heather. Yep. Okay. Making sure I'm going to click in the right places. It's quite the control panel up here. So I wanted to take just a few minutes to talk you through what our engagement process has looked like. Many of you have probably heard the term Delphi panel. I am going to characterize this as a modified Delphi panel for the primary reason that we are really approaching this from a qualitative perspective. Often a Delphi panel is going to be very quantitative. You're ranking things. We may get to that point, but our primary purpose has been to identify core themes that we really want to prioritize as we move towards development of these consensus statements. So we're using this process to gather information from our panel members. It is a technique that allows for iterative feedback to questions that we are posing, but also questions that the panelists are posing to each other. So we are really kind of providing some structure, but we are allowing for some flexibility given we have such a wonderful panel and we want them to be talking about the issues that are most important to the field right now. We pose questions to the panel members in two different ways. So we are actually doing some live but virtual engagements. Everyone is very busy, so it made sense for us to do this virtually. We are also engaging asynchronously. And when we engage asynchronously, and actually when we're doing our live engagements, we're using a tool called XLeap. XLeap is a tool that allows folks to create a virtual dialogue, not only between each panelist and the project team, but also amongst each other. So it allows for each panel member to see the question. They can see the responses that other panel members are providing, and they can engage with each other. They can pose questions to each other virtually. They can respond to questions. So it really is a nice tool that allows us to create that virtual dialogue that we're looking for so that we can move things forward. And we encourage them to log into the system multiple times so that they can see, has someone posed a specific question in response to your response? So it really creates a nice iterative process for us. We started the process in July, late July of this year. We are hoping to wrap it up by the end of March 2026. So it is a very rapid 8-month timeline to move through this process. And I will say the feedback that we're providing today is kind of a sneak peek. I will say for those of you on the panel, you haven't even seen these yet. So you all are getting a sneak peek to some of the major themes that we are coming up with based on your work. So as Heather mentioned, there's a lot of questions out in the field that are of interest. We are working to try to figure out how do we get there? How do we move the field forward to be able to answer those questions? And in order to do that, the panel itself is asking, we are asking, and they are responding to a certain set of questions. So some of those things that they have been responding to thus far, and the questions will continue. We have additional rounds of feedback that we'll be engaging in. Include, where is the evidence already well established? What things do we really feel confident that we know that we may not need additional investments in, so that we can then focus on the second question? Where are there gaps? Where are there needs within the field that need to be filled? And so that we can start talking about how do we fill those gaps? We're talking about what additional priorities or needs exist within the field. So even if it isn't a gap, what else is out there that you, from your experience, from the work that you're doing with patients, from the work you're doing with your colleagues, what other needs are out there so we can try to address those? And then finally, how should we address needs within specific sensory areas, looking at multisensory areas, looking at the field at large? So we realize that this isn't a one-dimensional conversation. And so the panel members have been talking about, where do we prioritize? Where are the greatest needs? Where's the greatest public health impact? So they're really kind of working through some of those sticky issues or challenging issues that the field is kind of negotiating right now. So based on our work to date, and again, as Heather said, this may feel a little bit deja vu given what we've just heard about, and then taking a look at the agenda, I think you're going to be hearing it again in your work group sessions and things to come. We currently have 10 draft statements that the panel has developed, and they fall into 3 primary categories: improvements to study designs, investments needed to sustain and advance the field, and then characterizing the desirable impacts to further the field. I'm going to share, so my next slide, I'm going to start sharing what these statements are, but I'm going to caveat it with, these are not the actual statements, because when we looked at putting the actual statements, they're a little long, and we didn't want you to have to sit through a really long list of slides. So these are summaries. I don't want you to worry about nuance of language. There will be a lot more built around these, but we wanted to give you kind of the core essence of the things that the panel has been talking about. And if you're on the panel, I didn't want you also to be worrying that we're distilling this way down. You will get longer statements to be reviewing in the next couple weeks. So currently we have 5 statements that focus on improvements in study design, which I think each of these are really unique and important. So the first is the need to implement well-designed studies. And we've kind of had discussions around, well, what does a well-designed study mean? Because I think anyone who does research and evaluation thinks my design is pretty well, it's pretty good. Like we're getting where we need to be. But I think that for this first statement, it's really getting to a level of rigor that is often challenging. So we're talking about randomized control trials. We're talking about longitudinal studies with long-term follow-up. So really the need for the field to move towards utilizing these very rigorous study design structures as they move forward as a way to answer some of these really complex questions that the field is dealing with. The second one is diversifying study populations. And the group has been very explicit that this needs to go beyond, it does include, but needs to go beyond race and ethnicity. We need to start looking at gender, age, global representation, and geography. Listening to the conversation in the prior panel talking about context, thinking about geography, thinking about resources, that contextual element as a community psychologist makes my heart sing. But really thinking about contextual factors as researchers think about population. And again, I think going back to the last panel as well, establishing a core set of sensory measurement tools and establishing a core set of cognitive measurement tools and ongoing validation of those tools, I think is two elements that have been critically important, and they've very intentionally been broken out into two separate statements. And then finally, for improvement in design, including patient and caregiver voices and lived experience. I think your next group is going to be talking about patient and lived experience. But the desire for researchers to really be making sure that they're pulling that in and not coming at it from just a researcher lens and perspective. Investments in the field. Investments is always tricky because the first thing that everyone thinks about is financial and monetary investments. We need more money in order to do the things that we need to do. So we've been very intentional at saying, absolutely, we want to acknowledge the need for additional financial investments, but we want folks to go beyond just the financial investments that are needed. So you'll see here, foster greater investments in collaboration to support comprehensive studies. The desire for additional collaboration has been a real key theme that we need to figure out how to get folks talking together and how to be working together. So that is a key investment within the themes that we've identified so far. And then the need to develop, train, and support early career researchers. I know there's a lot of early career researchers here today and listening in. And so the desire to ensure that there is a pipeline of folks coming into the field. How do you drive interest and investment with future researchers so that you can keep the field moving forward over the next decades to come? And finally, impacts. So the impacts here are what should folks be striving towards? And this kind of goes back to some of the questions we want to be able to answer. Emphasizing sensory function interventions. We heard a lot about the need for intervention. And so again here, how can we emphasize sensory function interventions to evaluate and preserve cognition or mitigate cognitive decline? So the desire for intervention work to be happening. Examine sensory loss across the lifespan. The group has talked a lot about how things often happen once folks reach a certain age, and the desire to say, okay, we need to understand sensory aging across a larger period of time, across one's lifespan, so that you can develop more effective interventions when someone is younger and maybe hasn't experienced significant decline. We can address some of those things. And then finally, using findings to inform guidelines for incorporating sensory assessment, clinical prediction, and intervention into routine care. Not just when an issue comes up when someone is sent to a specialist, but saying we need to be looking at these things as a part of routine clinical care. So what are our next steps? As I said, this is just a preview. We have 5 rounds of engagement that we're working with panel members, and we've only been through the first 2. So there's a lot more work that will be getting done over the next several months as we move towards development of a manuscript. The panel will be meeting to finalize statements, to do a lot of wordsmithing. In my experience, there's a lot of wordsmithing. People like certain words, they don't like certain words, and we're going to try to get it as close as possible so that it is globally accepted by the field. And I realize it's as close as possible. Everyone has their preferences. The panel will be providing input, not only on finalizing the statements, but also figuring out what do we put into this manuscript so that we make sure that it is salient and is going to speak to the needs of clinicians and researchers in the field. And then, as I mentioned, by March, we're going to be submitting our manuscript for publication. We'll also be working with the group to try to look at the consensus statements that you all be working with this week and developing to see where there are things that overlap, where there are things that are different. So we'll be in close communication with Jay and Varshini over next steps from this meeting and how it kind of integrates with the work we'll be doing. So just wanted to put this up. We really wanted to acknowledge the leadership and significant contributions of the Sense Network team. It's been an amazing group to work with, helping to guide us through this process. So we're really appreciative of that. And we did want to, at least if you have questions for Heather or I or our team, make sure that you have an email address and you know where to follow up. You can also reach out to Jay and Varshini with questions. Do we have a couple minutes? I know we're trying to, okay. Okay, so I just wanted to at least take a breath. We have some panel members in here. If you have something that you would like to add, or if there are questions from the group, we'd be happy to do our best to answer those. Lunch has settled in. People have had long travel days. Okay. Please don't hesitate to reach out. Let us know if you have questions. We're excited to be here and excited to be a part of this process. So thank you all very much.
Heather and Lori, that was wonderful. Thank you so much. And that was very exciting for us to see that sneak peek. So I really appreciate it. At this point, we are very grateful to have some patients here with us to share their perspectives. And Dr. Lindsay DeLotte will be moderating, so I'll invite her to come down.
Well, all right, I will go ahead and start. That's okay, no problem. I'm Lindsay DeLotte. I'm a neurologist and neuro-ophthalmologist. I'm at the University of Michigan. I will start with a visual description of myself. I'm a middle-aged woman with dark, short hair and glasses, wearing all black. I'm really quite delighted to be part of the Sense Network. I help to co-lead the Dissemination Translation Core. My research really involves vision impairment, healthy aging, and more recently have really transitioned into chronic pain research as well, and hoping to bring together those two fields in my future research. So thank you so much to all of our guests for joining us today. I hope that this is a panel that we can all
really learn from each other about really the priorities that we've been already talking about when it comes to healthy aging and sensory impairment in this space. So I'd like to just take a moment and introduce each of our panelists. And then from there, I would like each of them to go ahead and tell us their stories. So we'll start with our first panelists are Yevgeny Kuroshipov and his wife, Valentina. Yevgeny was born in Ukraine and came to the United States in about 1996, worked for Amtrak, sounds like for quite some time, and developed hearing impairment in 2012. And so he's going to talk with us about that experience. Beside him, we have Evan O'Neill, and Evan is a fundraising professional and a creator, a runner, and she actually started an organization, not-for-profit, called Brightside, which is really a support group and community for individuals with vision loss of any kind. And she'll be talking to us today about her experience with vision impairment. And at the far end, we have Elizabeth Yaffe, who is a film and media producer, as well as a writer. She wrote a fantastic piece in Slate, was it about 2007 or so? 2008, okay. About her experience with anosmia, olfactory impairment, which is something we've been talking a lot about, hearing and vision loss. And so Elizabeth's going to provide us with the unique perspective, the patient perspective regarding olfactory loss as well. So maybe we'll just start at this end of the panel and kind of work our way down and have you give us maybe a little bit, maybe start with you, Evgeny, about your experience with hearing impairment and then kind of work our way through.
Siberia and then came back to New York. So I came back to Ukraine working on design, research of power electronic equipment. I received in 1895, was granted American citizenship as a person of extraordinary abilities and started to work for Amtrak as a manager of service engineer group for SLA train. And once when I came back from work home, I felt pain in my right ear. I thought it will go away, and next day, unfortunately, left ear, then headache. So I understand something bad happens to me, worked with doctors. Doctors started to check my hearing, and a lot of investigations, but looking at results of X-ray, MRI, everything, they said to me that you've got a known virus which came through, but destroyed your hearing abilities. So it was my lifestyle changed completely because I was not able to communicate with someone by understanding what they speak to me. So I would only take some notes, and it was horrible what I mean communication with my wife, with family members, friends, etc., etc., etc. That time, I heard about the cochlear implantation, and I didn't know. I never had problem with my hearing in my life. Playing piano, playing guitar, singing, so no problems. And suddenly it happened to me without unpredictable. So about implantation, I was really impressed. The scientists years ago, they found that the normal sound comes into human ear and converts into electrical pulses, and through nerve goes to brain. That's everybody can hear, including myself when I had my hearing. Unfortunately, I was told that I can also go through implantation, but there are few things. Number one, it was very difficult to find out which one of them. As you know, of course, there are three manufacturers of cochlear implants in Australia, Austria, and the United States, Advanced Bionics. Number two, I was not young one, and being the surgery and the full anesthesia not so easy. So finally, and the very important thing is nobody could tell me if my nerve okay or not okay, because if it's not okay, it means the surgery will be for nothing. So finally, I decided to go through. So to be deaf for the whole rest of the life or go through this. So I decided to go, and the surgery was made in Weill Cornell in New York. And there were actually 3 surgeries because the first 2 were not lucky. So the third one was okay. And my audiologist, Dr. Jennifer Wu, was very nice before surgery, during surgery, after surgery. And in the months after surgery, he activated this cochlear implant. And in the beginning, in the first day, I heard voices as a Mickey Mouse, but it was very good sign that my nerve is okay. So gradually, month by month, it was better. In 2014, I have been invited to Valencia in California, to Advanced Bionics company, to participate in test of the next generation cochlear implants. In the beginning, it was Q70. Then it was they were working for Q90. So Q90 was much better, of course, but not as good as Q90 Marvel, which I have right now, because this Marvel allows you to hear from any kind of electronic equipment which has Bluetooth. So now I can hear my phone, I can hear everything via Bluetooth. So it's getting much better, but of course I have a problem when there is a sound around, for example, in the restaurant, or when I go in the bus, in the train, or whatever. So unfortunately, I had to go to leave my job and to become, yeah. So I'm now a retired person. So what I would recommend, to work, or let's say what is inconvenience for me. Number one, I don't know, maybe something changed for these years because it happened to me in 2012. But nerve, is it alive or dead, is very important. But to go through this very, through the surgery without knowing, it's not a good thing. Number two is the frequency range. Normal ear has range from 20 hertz to 20 kilohertz, depending on age or whatever. But cochlear implant allows 10,000, from 200 to 10,000. So it's not, it's enough for human voice, but not enough. So it's a music, orchestra, opera, etc. And number three is Q70 and Q90. The location didn't matter. I mean, you can cochlear implant from one side to another side without problems. But now there is a problem. And recently, excellent audiologists here in Boston, Dr. Gallen, she called to Advanced Bionic because one was for years, so something happened that I didn't hear for the left ear. So I was not able to put this one, the right side, inconvenience for case when you need to change some position. So this is my how I understand would be good if something would be better. Thank you so much for your attention, and never lose your hearing. If you lost, please take this surgery.
Thank you. Thank you. Next, we have Evan to give us her story.
Testing. Okay. Hi, everyone. My name is Evan O'Neill. And my story is, so I am a visually impaired young adult. I have something called Stargardt disease, and I can get into the weeds on what Stargardt disease is, but I'll start with my story, and I'll keep it brief because my story, probably along with many of us, could be as long as you want it to be. But so I was diagnosed with Stargardt disease when I was a senior in college. I was 21 years old, and I went to a small liberal arts school in upstate New York. And it came out of nowhere. A lot of visually impaired individuals I've met since being diagnosed, or anyone that has vision loss, a lot of them have a direct family member or someone in their familial line that has vision loss as well, at least in my experience. And I didn't have anyone in my family that had Stargardt disease or any form of vision loss, so it definitely came as a surprise. However, my whole life I struggled with my vision, so I knew something was wrong. And, I really started noticing signs of vision loss as early as 8th grade, but I'm a procrastinator, so I like to prioritize the fun things in life and put off the hard things a lot of the time. I've gotten better with that with age, but in 8th grade, I did not want to go to an optometrist and get glasses. It was not my priority. However, my vision definitely worsened, and, it got to the point where I stopped being able to see the board in class, and my parents and I decided it's time to get glasses. And so I did. And I thought they were helping, but they really weren't doing anything. And that I started to notice my vision just worsen and worsen in college. And when I stopped being able to recognize people as they walk by me on campus, and, I was an English and business major, so it required a lot of reading, writing, and speaking. I stopped being able to see the board completely, even with glasses, corrective lenses. And so I knew something was wrong. At that point, I didn't know that things like retinitis pigmentosa, Usher syndrome, Stargardt disease, diabetic retinopathy, glaucoma. I didn't know anything about any kind of vision loss. I just knew you either had glasses or you didn't. And so my junior year of college, I ended up going home, saw my optometrist that I had been seeing my entire life. And she said, you know, your eyes keep changing. I'm really perplexed. I don't know. Your eyesight keeps changing, your acuity. You need to go to Maine Eye Center. And I'm originally from Maine. My whole family's still up in Maine. So Maine Eye Center doesn't have the type of equipment that Massachusetts Eye and Ear has to be able to officially diagnose you with Stargardt disease. I mean, now I work in the field, so I know it's called an electroretinogram, but at the time I didn't really understand it. But when I was a junior in college, I was diagnosed with cone dystrophy. And, you know, that was just a general umbrella term of them telling me that something was wrong with the cones in my eyes, which is my central vision. And then the rods were in pretty good shape, which is my peripheral vision. So I ended up going to Mass Eye and Ear and was officially diagnosed about a month or so later on January 15th of 2020. So 2 months before the pandemic really hit with Stargardt disease. So all of that's to say is that 2020 was probably the hardest year of my life. I started out with this diagnosis of, you know, being 21, sitting in a doctor's office and them saying, you're losing your vision. There's no cure. There's no treatment. Have a great day. You know, you're going blind and you'll eventually be fully blind. We don't know how soon. We don't know really much about this. You need to go to Mass Eye and Ear. So I laugh now, but at the time I was not laughing. I was definitely crying and I was very lost. And I always tell my story and start with that because I think a lot of people being diagnosed with hearing loss, vision loss, any kind of disability that's going to affect your life for the rest of your life, it is like jumping off a cliff a lot of the time. You know, you're not really told where to go or what to do. And even if you are, that can be really daunting and scary because you have this new sort of label and it's really unfamiliar and uncomfortable. And so after my diagnosis, I fell into a pretty dark place, if I'm being honest. I did not want to deal with it. I didn't want to cope with it. I was very much more into athletics than academics, and I didn't want to have to face not doing any of that stuff. Didn't want to tell my friends because I didn't know what it meant. And eventually I started running, and that's why I added that into my bios because I still am a runner, but very much in the beginning of my diagnosis, running changed the way that I saw myself and my diagnosis. And it was like in the pandemic, you either drank in your driveway or you ran. And I was like, I did both, but I decided to try and run as much as I was doing other things. And so I started to tell people through running about what was going on. You know, I have this thing called Stargardt disease. I lose my vision. It's crazy and I don't know what to do. And I did my first half marathon, and that was my way of, and it was during COVID. So all half marathons were either postponed or canceled completely. So it was like a DIY half marathon through my coastal town in Maine. And I did my first fundraiser. And that's when I realized the importance of sharing my story, how much it meant for me and eventually others, and how important it was to spread awareness about these types of vision loss and disabilities and the importance of private donations when it comes to fundraising and funding clinical trials for these types of vision loss and disabilities. And I'm 27 now, so it's been about 5 years since my diagnosis. And I have realized the importance of community, patient advocacy, spreading awareness and education, and being honest with where I'm at, because like I said, it's helped me so much in my journey, and I believe it's also helped others. I started sharing my story online. I'll wrap up soon, I promise. I started sharing my story on social media, and I wasn't a big like social media person, but when I did my first fundraiser and shared my story, there was a lot of feedback from people that came out of the crevices of the corners of my life. Like my mother's brother's grandmother has macular degeneration. You know, my cousin's brother, Scott, he actually has Stargardt disease. I'll connect you with him. So I started to realize there was this community of people out there that had never talk to anyone else that had vision loss. And at that point I hadn't either. Since it was life-changing connecting with these people, because I think my family, loved ones, and sighted supporters, as I like to call them, can understand and be empathetic and supportive. But there's just something completely different about being able to connect with someone that actually knows what it's like to go through this. Even connecting with individuals who have hearing loss understand what it's like to some degree, to lose this sense that is, a lot of times feels irreplaceable. So all that's to say, a couple years ago, I was at Mass Pioneer for my yearly appointment, and I have a great physician over there. I adore her. She's the one that officially diagnosed me, and I felt like I was just immediately in better hands than Maine Eye Center. No offense to Maine. I just think that healthcare in Boston is unprecedented. It's just the best. And I saw this eye chart in the waiting room, and I hate eye charts. You can imagine why. I just hate them. And it said, always look on the bright side. And instead of having a giant E at the top, it had like an A. And I remember my dad pointing it out and saying, that'd be a cool name for a support group if you ever started one. So I did. And I started the support group and community called Brightside about almost 2 years ago in February 2024. And I reached out to five or so people I had connected with over the years to see if they'd be interested in joining this thing that I would run. And I'm not a licensed clinician, but my parents are both social workers. So I had some sense of how to facilitate a group session. And those 5 people came, and now it's almost 200 people. And I run meetings twice a month, every month. And my community of visually impaired people, I think, is the best. It's the greatest asset in my life. And I just think that disabled people are the coolest, most unique, most creative, incredible groups of people I've ever met in my life. And I think that they are doing things above and beyond every day that should be so recognized and celebrated. So yeah, that's my story. I actually work at Mass Pioneer now, so it's very full circle. I fundraise in the ophthalmology department, assistant director of fundraising for leadership gifts in ophthalmology. So I now fundraise for that doctor that diagnosed me, and my life is, touches vision loss personally and professionally, and that's the way I like it. So it's definitely made me who I am. Thank you.
I'm very moved being on this this panel. And I'd like to just thank all of you as clinicians, because I've had many medical issues throughout my life, and seeing the welcoming of patient stories and knowing how important it is a real breakthrough from when I started having my issues. So thank you all. So I first began to experience anosmia in 2005. I had moved recently to a lovely little home in Northern California, and shortly after that began to have terrible allergic reaction to something. And it just kept going. And then a cold came in, and eventually I lost my sense of smell and taste completely. And rather than going through everything that I tried, I will tell you that that lasted for 3 years, and eventually forced me to move back to Massachusetts, which was a good thing. But in that time, I learned to appreciate the sense of smell in a way that I never had before. And then I'll speak about taste too. But I did a lot of research during this time, and I read a book called The Scent of Desire by Dr. Rachel Hertz. And she pointed out that most people don't value their sense of smell. And that she cited a study that people put it at the bottom of the list of what's important to them with the senses, and they considered it equivalent to losing a big toe. And if you think about it and you haven't had any impairment with your sense of smell, you can take a moment to notice that you're actually receiving signals all the time right now in this room from yourself, from the environment. And what I discovered was that the sense of smell is absolutely vital to orienting yourself in space, in your own body, even in your mood. That's a big one. So as I went through this issue and kept thinking, oh, this will get better, this will get better, and it didn't. It changed my outlook on life. It changed my personality. I had many, many issues with eating because, of course, well, let's just describe it since Thanksgiving is coming up. You can imagine that every time you have to have a meal, which we have to in order to survive, it's like approaching something that tastes like sweet, salty, bitter, umami, and sour cardboard. And I say that to say that, you know, I'm sure you all know that you can maintain your sense of taste when you have anosmia, but flavor no longer exists. So you get used to trying to over sweeten, over salt, over bitter things just to get some kind of sensory stimulation. And this can lead to either not wanting to eat or wanting to eat too much because your body is desperately trying to get some feedback. So one other thing I want to say is to put this in context. I'm actually a stroke survivor. I had quite a massive hemorrhagic stroke at the age of 30. And I wasn't expected to be in the condition I am now. That's a whole separate story. But the reason I bring that up is I lost all feeling on my left side. So that was another loss of sensation. I still have diminished feeling on that side. I still have to watch how I walk. I still have other deficits despite my good recovery. And I will say without a doubt, losing my sense of smell and taste was far more traumatic for me because of the continuing quality of life issues. When I go back to Thanksgiving, I'll say, okay, imagine walking in, you cannot relate to other people in the same way. You touched on this. Both of the other panelists touched on feeling isolated and feeling like the basic things we take for granted. Again, going to a holiday and you walk in that room and you smell the aroma of all the cooking and then everybody's talking about how delicious everything is. And just like not being able to hear or not being able to see, you start to shut down inside and withdraw. I tend to be able to put on a good performance of enjoying things because I don't want to bring things down like, oh, how was the delicious meatloaf? It's great, you know, because you don't need to go on and on as this is continuing. So that was a very important thing to understand the level of isolation that losing senses creates, and then trying to live with that. And I am very fortunate because my anosmia, as I said, was caused by inflammatory response. It turns out I was later diagnosed with chronic rhinosinusitis with nasal polyps, but this was also tied into having AERD. So that really came on strong. That particular condition, which used to be known as Samter's triad, affects your lungs, affects your sinuses, affects all of your mucous membrane. So the whole respiratory system went out. It eventually affected my hearing to the point that I lost 80% of my hearing because of eustachian tube dysfunction. So I have an understanding of the loss of the senses. Luckily, as I was saying, I did move back to Massachusetts. I was able to be treated by Dr. Eric Holbrook, who changed my life for the better. He reconstructed my sinuses, which were basically non-existent at the time in terms of being so inflamed and having no ability for the air to get to the olfactory nerve. And my sense of smell returned. I managed it. He gave me a chance to manage it through steroidal nose washes, etc. And that continued to be managed for many, many years. Now, this leads me to where I'm going in terms of research, because within the last 6 months, I would say, the flares that I had, which brought back the anosmia, have been far more frequent, to the point that I could go for a month at a time, if not more, with anosmia. And that was okay, but then it kept happening. So I had to start going into the prednisone cycle. And prednisone is the greatest and the worst, as you all know, treatment, because for me, it works like a charm. But I know that staying on it, you can't. So I'm going to move now into just what I think in terms of possibilities for research. I should say that I do kind of speak layperson and medical jargon, because I went back to school and I studied different forms of medicine and medical research. So I read a lot from PubMed, et cetera. I noticed that there was some research being done for inflammatory diseases, such as mine, where you take low doses of prednisone or other corticosteroids and intermittently. What I learned by experimenting on myself, yes, I did, was I didn't need the long, taper. It starts at 60 and goes all the way down for weeks, which can be very dangerous over time. I could get by with a short burst at a low dose. And I started to ask my doctors, can you just give me some to use? And of course, the answer is no. We can't have you playing around with prednisone and not knowing what you're doing. So I would ask all of you who are in these fields, and again, I know that inflammation plays a big role in a lot of loss of senses, to really start to look at what can you do with corticosteroids at the lowest level. Does intermittent work? Is there something else that can really target inflammation that we can go to? I'm going to get to biologics in a second. I also would ask you to keep your minds open to integrative therapies, because, for instance, I'm doing salt therapy, go to a little booth and inhale salt. I'm finding it has kept my flare. I haven't had I can taste and smell right now, which is really amazing. It's been, usually at this point, I wouldn't be able to. I did start Singulair. That really did help me because it kept the lung condition at bay. And that, of course, affects the whole body. That's not integrative, but I find that to be helpful. And I explore other options that are going to complement the Western medicine and that will keep my body less in the inflammatory cycle. So I ask you all to stay open to what else is out there that's actually helping people in a different way. Now, I want to end on biologics, because of course, Dupixent, things like that. When I asked Dr. Holbrook, do you have anything that you can help me with now that's come into being since this started? And he said, well, we do. We have biologics. The good and the bad for me is that I research too much. So, and I'm a person who's had multiple, as I said, medical issues and already have some mobility issues and other things. So I'm very, very leery of starting something else that honestly, I'm not sure it's been out there long enough for me to feel comfortable. And the way I would put it is this: as clinicians, really pay attention to the pattern you're seeing in your practices about people having side effects that they cannot live with given these new medicines. I know for some people it is a life changer. The reason I won't go on them right now is very specific. When I go into a cycle of anosmia, I can still present. But if I end up switching that out with having very severe conjunctivitis, my eyes start to get affected, other issues like that. And then the one that I read a lot about with Dupixent was people having extreme joint pain, sometimes having to be hospitalized. So that may or may not happen to me, but as a person who already has to handle enough things as I get older, especially, I'm not willing to do it. So I would just ask you to look again for more patterns of what's really going on out there with the biologics. And these are barriers to usage as well. And to understand why people might say, I know it could help me, but I'm not willing to do it. That's basically my story and my thoughts. And again, I thank you all and thank you for what you do. We are very grateful.
So we do want to open it up to questions from folks in the audience. But first, I was hoping Valentina, Yevgeny's wife, might tell us a little bit about the caregiver experience, which was something we had heard about in the last session, and I think is an important voice.
First of all, briefly introduction and description. Those who are visually impaired. I am Valentina Urashepova. I'm 83. And it happened that my husband lost his hearing in 2013. And I had to be a caregiver through all these years. So the only thing I can describe to you what goes with that. Practically every panelist who spoke now mentioned that it's a hard journey and lots of things go at the same time. With Evgeny, it happened like a sudden onset. He lost his hearing on both ears within 1 month. We were running doctors like crazy, but practically the thing is that unless you have a diagnosis, you don't know who to turn to. So there were a lot of ENR doctors, primary physician, whoever, and nobody actually could tell us what's the matter. The closest to diagnosing they came was after the fact that after he lost his hearing, and they took his spinal fluids, and the closest to diagnosis was meningeal signs. Where could that come from? It's beyond me to understand. But the accompanying thing always with sudden loss of hearing, vision, or any other sensory quality is it's confusion. It's physical confusion because the person can't do what he used to do. It's mental confusion as well. The first question, why me? What have I done? You know, it comes as a punishment. And then the person at that time is high strung. When he anybody who is hard of hearing and the people who are around him know that he cannot control the volume of his voice. And when you are at a shop or at a restaurant and your husband starts yelling at you, people think that we have a very bad quarrel. And you, at that time, you think, oh God, he hates me, what more? I do so much for him. But you have to remember at all times that it is not because he wants to. He cannot control his hearing and his voice at the same time. Another thing, but that is for, mostly for people who are around you. You are, as a caregiver, it's you and only you and nobody else. And however bad you feel, his situation is worse. But you feel bad enough, believe me. It's like you're losing your mind right next to him. Just imagine, a month ago you were talking, you were a normal couple, and then you sit next to him in a car and yell at the top of his voice, of your voice, and he doesn't blink an eye. That is like crushing. As for, well, I don't want to dwell on caregivers. If you have any extra questions, ask me later. I'll be happy to answer. As for the achievements of the group who is working on sensory approach, Evgeny mentioned that he was invited to California, and the lab we worked with was very nice. They took us, they have a museum of the development of cochlear implants. So it started like that big box. And now, as you can see, another thing is when he finally found out that his hearing is gone, he went through 3 surgeries. 2 first are failed. I will not be dwelling upon it. But when it failed, you actually don't have an idea why everything was supposed to be different. And the doctor just can't do that. So Evgeny called the head of AB institution and asked if there is any hope that the sound will be ever better, because at the beginning, after the failed surgery, he just heard indistinguishable noise. He said never, ever. So then there is a decision to go for second surgery. Then it happened the third. Well, but you don't know lots of things. Lots of people who lost hearing, even especially younger ones, they think that, okay, they will do the surgery, everything will go like that, I will do it tomorrow. No, the approach is way too optimistic. We learned by sheer chance that the implant, if not properly done, or if you need to change it, it gets encapsulated into the tissue of your head. And the surgery is going to be much harder. But I mean, you have to go with all that. And he doesn't hear, he doesn't understand. So the caregiver is an interpreter from that to any other language. You are. You also have to take care of, like, you know, with physical art, like with daily things, because it never goes alone. With loss of hearing, there's loss of balance. And there is some kind of, I don't know if it's always that way, but with Evgeny, it was like his vision changed in a way. See, when you look this way, and then you look that way, so you see a picture here, a picture there. With him, it was like the previous picture flowed along. And so he doesn't really see what is in front of him. I'm sorry. I mean, lots of things go together, and you don't know who to turn to for help. So you waste a lot of your time running from neurologist to ophthalmologist to ENR to whoever you can think of. So from that point of view, as a suggestion to the further activity of this group, somehow the results of your research have to be brought down to the field, so the doctors would be able to know what could possibly go wrong, what could happen, and how to advise the patient on his further steps. In California, they invite doctors for training for surgery. And I know that practically every surgeon has his own plan of the surgery. Now they're doing it much easier. We saw people who had surgery comparatively recently, and it's not making a dent in your skull, but something behind your ear. So it's easier, and it's now considered to be a one-day procedure. With Evgeny, it was lots of anesthesia, and I mean, it also had his effect. So there were cardio problems after that, whatever. And one thing I started about how much is done, but there is still more to be done. So I'm happy that we can bring in something into it, some knowledge. Also, there is, I don't know if the group is aware of that. There are spontaneous support groups. There is a website, My Hearing Journey, where people share their experience with surgery, losing their hearing. And you can participate, you can read their stories, you can see how many and what is happening. As for the rest, you know, however, whatever happens, I just wanted to give you a mantra, which was my leading mantra through all that. in simpler ways, if you remember the sounds of music, do you remember? If God closes the door, he opens the window somewhere. So that, and I found it at one of psychologists that everything will be good. Maybe not as you think, but everything will be well eventually. You will pull through, everything will be fine. Thank you.
So I think we have a few minutes, and I'd just like to open the floor if anybody has any questions for our panelists. I have no idea. Yeah. Oh, Kathy, can you unmute?
Yeah, I just had to mention Rachel Hertz, who you saw about smell. She was my classmate. So she was studying smell and memory when I was studying hearing and memory. So it's all coming together. But I think the last comments that we heard about what you would like other health professionals to know. So you've all had experiences going to your specialist, but oh, can you guys see the captioning? Maybe they're turning their back on that. But if you think about, you're not going to your specialist, you're going to another health professional, you're going to your family doctor. Is there, one thing that you would like them to know that would help you to get better health care for things that are not directly related to your sensory loss?
Can you hear me? Okay.
Yep.
I really think, as I said when I opened, just the fact that there is more interest in what the patient's lived experience is, as opposed to what you're trained to do, which is be an observer of that lived experience and to measure it, to quantify it, to figure out how you can, do more research, to really listen more closely to what the human aspect of it is doing, so that when you do suggest treatments and when you are there as a guide, you're looking at the individual, not the statistical model necessarily. Now, of course, one's going to inform the other, but I would say to really be present with the patient and understand where they're coming from, make that the priority.
So is there something you would like every doctor, every health professional to know about vision loss? If you pass the microphone along.
Oh my goodness gracious, sorry. Not necessarily something, oh my gosh. Not necessarily something I would want them to know about vision. Well, actually, I take that back. I think two things. I don't know if this is like, I'll grab this. Testing, okay. Two things. Okay. I had a completely different experience at Mass Eye and Ear than I did at Maid Eye Center because that physician had really good bedside manner. I was, like I said, 21. I was terrified. I had no idea what was going on. It was devastating. And the way she presented the news of Stargardt disease to me at Mass Eye and Ear was, I see patients with this every day who are entrepreneurs, teachers, educators. They are, not driving race cars or flying fighter pilot. They're not flying fighter jets, but if there's a will, there's a way. And they are some of the most incredibly talented and hardworking people I've ever met. And that's going to be you. No matter what you want to do, this isn't going to change anything. And I understand people are different, physicians are different, and sometimes you just want to deliver the news and you need to move on. But I think that changed my life. When I was at Maine Eye Center, they gave the news, left the room, said I'm going blind, and that's it. And there's nothing we can do. And I think the diagnosis I had at Mass Eye Near was just a world of difference because of the way that she presented it to me and her bedside manner. I'll say that, and then I'll also say if there's one thing I want every physician to understand about vision loss, and they all know this, I think, especially in inherited retinal disease, is that blindness is a spectrum. And to your point, every patient is going to have a different lived experience and a different story. Some use canes, some have service animals, some, wear dark glasses, some it's completely invisible and you have no idea that they're visually impaired. I think a lot of physicians understand that. That's more just general public of the world that needs to understand that. But that's what I would say.
Sounds like we also have
Okay, so I'm gonna, tomorrow I'll pick up the functioning and communication. So thank you for that.
Sounds like we have one more question in the chat. Yeah. So how would your experience have been if your doctors had made a plan to address your mental health in the context of your sensory loss? Any one of you who feels comfortable answering?
Okay. That's a great question. Once again, I would go back to saying the only way to do that is to really understand who you're dealing with, who your patient is, what their own particular mental health needs might be. When I went to one doctor back out in California, and he told me that I would never get my sense of smell back. That's the first thing I would say. And I say it also as a stroke survivor who was told I wouldn't be able to use my left arm and hand or probably walk without a cane and a brace. It's really important not to help people understand, to adjust to their situation, but also not say things that are going to just sap people's energy, make them have no motivation. I think it's very, very important to say we don't have an answer right now, but there's always more research. You should be looking into things for yourself. Encourage the patient, encourage the doctor-patient working together instead of coming from on high and saying, this is where it ends for you. And I think it would have been helpful to have the doctor say, what do you need from me to support you emotionally? Ask the patient and don't just assume.
Well, thank you so much to our panelists for, coming here, sharing your story with all of us. And if anybody has any additional questions, hopefully you guys will be able to hang around for a few minutes so people can come up and talk to you. So thank you so much.
So we now just have a very quick introduction to our working groups, which we will start this afternoon. So I invite at this time Dr. Varshini Verdaraj and Dr. Jan Pinto to come to the stage to introduce how the working groups will function. And then we have a coffee break for you. So thank you for sticking with us so far.
Great. So well, I wanted to just thank everybody for coming. This is really exciting, small meeting where we can interact and talk about our different interests in this field. I think this session, the idea was to motivate, why are we all here? Sometimes, you're buried in papers and grants and research, and it's nice to remind everyone that, sensory function really affects people. I think we all understand that. So the idea here is we're going to get together in groups and kind of work on where is the field, where are the gaps, where are we going, and talk about ideas. We want it to be as interactive as possible. We'll do that in 3 different sessions, 1 today and then 2 tomorrow, and those will culminate in a presentation back to the group, a little report out where the leads in the sessions will report on the findings. So it's meant to actually, discuss things, but actually work towards a goal. We hope that you'll find it fruitful and enjoy the discussion. So I'll turn it over to Varshini to just discuss the logistics and the mechanisms here.
I don't know.
Hi, everybody. Thank you all so much for being here. And as Jay said, the goal here today is to sort of synthesize what's already known on the topic of related to sensory aging, cognition, and late life well-being, identify current data gaps, and then set sort of priority research areas to be addressed across these 5 workshop groups that everyone's been assigned to. And they are measurement, intervention, mechanisms, technology, and then policy implementation science. You have them at the back of your badge. If you're not a workshop lead and one of the participants, you should find at the back of your badge. Oh, oops. I just realized you were not seeing this slide. Here we go. And then so, yeah, we really encourage you to think big and outside of the box, explore interdisciplinary ideas to uncover interdisciplinary solutions, and really irrespective of which workshop you're in, think about common themes that cut across the workshop, such as thinking about social determinants of health, the economic impact of these conditions, and issues specific not just to high-income countries, but also in a more global context and specific to low and middle-income countries as well. And then also opportunities for interdisciplinary innovation and accessibility. And as Jay said, this output will ultimately be used to build consensus and craft recommendations for setting priorities in sensory aging research. And we also know that while the idea is to arrive at a consensus, that not everybody might agree on exactly what the gaps are and what priorities need to be set, and that's okay. Bring all of that to the table. We want to hear diverging perspectives as well. So there's going to be 3 breakout sessions. The one today is issue mapping, and that will begin at 3:30 after some coffee. And then at the end of that, you will have created sort of a slide on what you know and what we know and on the topic and what the current gaps are that the leads and co-leads of each group will be preparing. So over the 3 sessions, 1 today and 2 tomorrow, at the end of that, each group will prepare a 10-minute presentation for the plenary session that will happen at the end of tomorrow. And we ask the senior workshop leads to present on behalf of their group unless another participant is designated. And yeah, the presentation components, as we've all said multiple times now, is what is already known on this topic, what are the current data gaps, and what are the research priorities in the short and in the long terms. And thanks again to the work group leaders who've so kindly agreed to lead the discussion and lending your expertise and time. We're very grateful. Here's the names of all the leads and co-leads for each team. I won't get into it because you will have more in-depth introductions once you get to the work groups. And here are your room assignments. The rooms are laid out all across this big conference center. So just look for a sign. There'll be digital screens outside of the rooms. And if you just look at your work group, just look for the room that's in the second column, and you can make your way there after coffee. And we'll see you all back here at 5 p.m.
Thank you. Okay. Thank you. So we were just checking in with the room to see how work group discussions went today, and I think they seem to go very well. So we can be fast with this kind of wrap up, but we just wanted to start by giving some really important thank yous. Without the folks on this screen, we would never have had a conference. And so a huge, huge thanks to Suze, who is our communication specialist, who really is the one who put all this together. You know, Jay and Varshney had a vision and she made it happen. So thank you, Suze. And she was assisted by Mindy, of course, who keeps everything running for us together at the Cochlear Center. And then we're so, so grateful to have Justice and Katie join us again today too. Like, thank you guys for stepping up and being here. We needed you and really appreciate that you were here. I realized that I didn't say this morning, and I probably should, but maybe it's, since I'm the director, maybe it doesn't matter quite so much, but we do want to thank the Johns Hopkins Cochlear Center for Hearing and Public Health, who, even though we did not pick the snacks, we are providing the funding for the snacks. And so so grateful for that too. And also thank you to everyone who participated today. This list will only grow tomorrow. So I want to thank all of our panelists and all of our moderators. Want to thank especially Heather and Lori from RTI. Want to thank all of our Delphi participants, as well as our patient panel. Really appreciate them coming today. And so just to remind you, kind of when we started this morning, we said we kind of had 4 overarching goals for this conference today. So our idea is we really want to build consensus of research priorities, address current knowledge gaps, and identify actionable next steps in the field of sensory aging, cognition, and well-being. And of those 4 things, really, we did a lot today. So we had reflections on our progress in recent years. We talked about the Delphi, and then we also talked about the patient perspectives. And so really the focus on tomorrow is going to be on developing those consensus recommendations.
Great. And so real briefly, we'll just go over the agenda for tomorrow morning. Again, all of you guys have this in your folder, so you can reference it at your leisure. We'll get started earlier tomorrow than we did today. So I think bus is 7:30, is that right? 7:45? Yeah. On the coming slide, stay tuned. But we'll get started here with breakfast at 8 o'clock. A few words to kind of kick things off. And then we'll jump into the session on inclusion and translation. And that'll take us up until 9:55 with some time for question and discussion at the end there. But really kind of one of the purposes of this session is for us to be thinking about where we take our findings and how we make our findings relevant and applicable and move them into actual translation policy, those sorts of realms. So hopefully some good conversation coming out of that. And then after a break, we'll be breaking into to work groups, some deep dive discussions, and then coming up with recommendations. That takes us through the morning. After lunch, we'll have presentations from each of the work groups and discussions. So think about that as you're in your work groups and talking about how you want to, we're not being prescriptive at all, however you guys think is best to present to the larger group and to foment discussion among the larger group about your specific topics, open to whatever makes sense for you guys. And then we'll talk about kind of again coming full circle, following those discussions, how are we going to bring those from this consensus that we've hopefully built into action? And we were meant to have a session at the very end, including a bunch of our program officers from NIH. For reasons that I'm sure are clear to all of you, they were unable to participate with government shutdown, unfortunately. So our last, we will end this and then go on to the poster session where we have various presentations on work that's being done within the Sense network, as well as sensory aging work that's being done outside of the formal network. And so some really interesting posters that'll be presented. And we hope that everybody will be able to stay through that before heading to GSA or the airport or wherever you're headed Tuesday evening and Wednesday. So we have a busy day tomorrow and look forward to really making some headway. So here we are. The bus will depart possibly before 5:45. I think if everybody's at the bus and ready, but by 5:45, and then tomorrow we'll be leaving by 7:45 to head over here. So thank you guys for all of your engagement and for being here and for all your contributions today. And we look forward to a productive day tomorrow with everybody.
Thank you.